lot of these slides you've already seen before. We're going to go through them kind of quick, but as you all know, you're here because of the prevalence of peripheral vascular disease, and knowing it's one of the third leading disease states that we have in the world and the nation. Interesting, if you'll look here, there's approximately in the United States, by this study, there's approximately 12 million PAD patients, only 2.3 diagnosed. Of those, 1 million had procedural interventions. Now, procedural interventions does not mean just passing a wire in a balloon or a stent. It also includes surgery and bypass. If you look, over half of these people had bypass and amputation. Over half of the only 1 million of 12 million that were treated. So you need to take that into account as far as diagnosis, getting the people that you work with, the population out beyond that, and as well as your primary care doctors, all your referrals, you need to let them know what you can do, because it can make a huge difference in the amount of peripheral vascular disease that you can treat wherever you go. Now, taking a little bit of approach here, we have a toolbox. Now, this is an old slide. It's been around for a long time, but it also represents some of the things that we do. And in your toolbox, you got a variety of things to use. Now, as you well know, you've seen specialty balloons, you've seen stents. You just had an excellent talk on stent placement. And then we can talk about other devices that you have. I'm talking about atherectomy today. Unfortunately, over the years, not being a young man anymore, I've been able to participate in every atherectomy trial that has existed in one form or fashion, and have been able to use each and every one of these. And you know, I'm an interventional cardiologist. I have an opinion, and I'm an opinionated person. I have no mind telling you. And some of the things that you learn and some of the things that you're told by various sources, you need to be careful. So I will probably tell you my opinion as we do this. Let's first talk about directional atherectomy. Directional atherectomy has been around for a long time. Back in my younger years, before we placed a lot of stents in the coronary arteries, we actually did DCA of the coronaries. You'd put a 11, 12-French sheath in, take a 12-French guide up there, and you'd DCA, especially bifurcating disease. It worked great. To me, it's a very good device. There's only one reasonable trial that they've done, and it's actually, this is the Silverhawk Directional Atherectomy, and this is actually a registry that they did. And they had endpoints, and you always look at the endpoints, 6 and 12 target lesion revascularization, okay? So they enrolled quite a decent number of people in the trial, had above and below the knee, and as you look at the 6-month data here, 90% at 6 months were free from target lesion revascularization. Still probably had some degree of restenosis, but not enough that met the criteria to revascularize. Then when they looked at 12-month data, 80%. That's pretty good. That's pretty good. Now, that's with and without adjunctive therapy. Adjunctive therapy could be provisional stenting or also just balloon therapy. And 80 to 90% from target lesion revascularization, not much complication, pretty straightforward device. Now, I use this device quite frequently, and I like the device. It's a little cumbersome. It takes a while to do it. You kind of put it in, have to take it out, empty it, put it back in. You can do long lesions, but it takes a long time. I like it for larger vessels. It's real good for common femorals. It's real good for bifurcation. Here's a lesion at a bifurcation right here. You don't even see your profunda coming off here and your proximal SFA, and it looks like they got pretty reasonable results. They were debulking this. Now, I will tell you, and there again, I like it for bifurcating lesions, and sometimes because putting a stent right there is not the easiest thing in the world, or doing other modalities. One of the things that depending on who you talk to, but I do believe in post-ballooning these. I'll take a low-pressure balloon, same size as the vessel, take it up to low pressure, and I'll let it sit there. Now, I'm kind of known for my balloon times. I'll leave a balloon up for 5 minutes, slowly take it up, leave it up for a period of time, slowly take it back down. Those are proper techniques that were taught back in the 80s by Brunswick. And you can actually get very good results from this. Here's a long SFA lesion we did, and it's not bad results for just atherectomy and alone right through Hunter's Canal there. And then you can go below the knee. The other thing I will tell you, when you're doing the larger vessels, now when you're going below the knee and using this device down here, it's difficult to do. But when I do larger vessels, I will put a distal embolic protection device down. I don't care what they say. Once you've been burned once or twice and you spent 4 hours chasing something that you created because you didn't do what you thought initially that you would because you're trying to save a few minutes, you're trying to save a few minutes and you take a few hours, it's worth putting a distal embolic protection device down and catching the stuff that breaks loose. You're taking a device back and forth across a lesion. You're having to remove it and put it back in, and it does a good job debulking, but you can also shower. So my advice is that no matter what they tell you, unless you want to spend a couple of hours someday, I would put a distal embolic protection device down. Laser. This is the other modality. The directional atherectomy has probably been around first before anything. Laser was probably the second one to come out. I believe that Excimer laser is probably the most versatile of any of the atherectomy devices. Though you may not get the luminal diameter size that you want from atherectomy, it is the most versatile. Using the coronaries, we use it, have used it everywhere, and it's actually the one that has been approved for in-stent restenosis. They've had several studies on long chronic occlusions. They get pretty good result. Secondary patency rates of 75%, and there's been studies on short occlusions too, and they got very good results with that. This is the LACI trial was one of the pivotal trials that they did using laser for critical limb ischemia, which you'll hear a lot about critical limb ischemia at this particular meeting that we're at, okay? And we participated in several of these trials. This is a gentleman here who came in, went to several doctors, had been bypassed twice, lost both of his bypass grafts, got a staph infection, was in the hospital for about a month with a staph infection. Nobody would touch him, no surgeon would touch him, and he came to me from northeast Alabama. And interesting, if you look here, probably his problem with the non-healing wound was the fact that here at his profunda, he's got a lesion in his profunda, and that's probably, and this actually had bypassed pretty fair distally, and that's probably was the reason that he didn't. He had horrible ABIs. We worked on him several hours. We're able to recannulize his entire SFA and popliteal. If you look at this one right here as it passes the knee, that's actually a collateral that comes from profunda because all this did was come down to his anterior tibial. So right here at this level, this collateral comes in the anterior tibial right here. His popliteal was not open. All you saw was the proximal anterior tibial. Unfortunately, he had an artificial knee, and we ended up having to work with the eye sideways and knee bent up, and it took several hours to get this open, but he still has his foot and his leg, and he was looking at amputation. In the LACI trial, you can see the vascular, all the different lesion lengths they have, and they worked on you can use a laser from the level of the SFA all the way down to below the knee. This is some patients that were done in the LACI trial. You can see the wound here. This is their lesions that they had. We went in and cleaned out the distal popliteal and proximal tibial-perineal trunk, restored flow, and this right here is after 6 months. Get straight line flow. If you can keep straight line flow for about 3 months, you'll heal these people. They will heal. This is another patient that had, and after going in. Interesting, they had a fairly straightforward, simple lesion that was opened up, created straight line flow. 6 months results of LACI, survival with limb salvage 93%. So at this particular trial that was very successful. Interesting, laser is the only atherectomy device that's done randomized trials from comparison to balloon. They just did a trial with the directional laser that they have and compared that to balloon. It was fairly successful too. And that's where they got the in-stent restenosis indication also. This is the orbital atherectomy. Interesting, the orbital atherectomy is based on, or rotational atherectomy is what it is. It's called orbital, but it's rotational. Rotational atherectomy has actually been around for a while. We were doing a rotational atherectomy in the early 90s, around 93, 94, 95 in the heart when it came out, and it was the rotablator. And we actually used that below the knee back in the old days. I guess old days. I'm feeling older every day. But this is a little bit different than the rotational atherectomy. The orbital atherectomy is weight on one side. Now, the analogy that I give with this is that I don't know if y'all wash your clothes or not, but I'm a country kid and we had to wash our own clothes, and going through medical school and everything, you just wash your clothes. If all your towels got over to one side of the wash machine, after a while, once in the spin cycle, you'll see as the faster it spins, it gets larger. And that's basically the centrifugal force. That would be the analogy that I would give for this, because as it spins faster, the weighted side will make a larger lumen. Now, this is fine and good. I will tell you, this particular device is very important in calcification. The two things I think in interventional cardiology, intervention period, not just cardiology, but intervention, I think that calcium and thrombus are our worst nemesis, and we still don't have a good handle on both of them. We do a lot of things to them. We still have not got a real good treatment. This actually can do a pretty good job. This device works best if you have circumferential calcium all the way around. And I'll tell you, looking at this, this actually is a slide of a patient I did when I went up and did their Cadaver Lab and worked with them when they were first developing this. This patient here, they've got some calcification in there if you look at the IVUS, but it's not as heavily calcified as we've seen in the past. It worked great on every type of lesion we saw in the Cadaver Lab. And I couldn't, and then I came out in private practice, I mean, when I returned back to where I was, I couldn't get it to work on a lot of different lesions. I IVUSed at least 20 of these in 1 month. And we didn't get the results we got in the lab unless it had circumferential calcium. And what I figured out after a while, I got a degree in biochemistry, and what do you use for cadavers? How do you make them cadavers? Formaldehyde? Yeah. So you give them formaldehyde, and what that does is draw all the water out of the tissue. So every one of the lesions we did in the Cadaver Lab was hard as a rock. And that's how come it works so well on so many different modality of lesions. But you'll find that this right here, which is, it's got some calcium, but it's not as heavily calcified as we see, it doesn't quite work on soft, because it's like, you know, I don't know if you're cardiologists, you know, whenever you're under duress, you're going to take the path of least resistance. Well, that's what it does. It does the same thing. And that goes back to the hospitals. They did a trial with it. It came out relatively well. It's the orbital atherectomy, I think, is best used in heavily calcified lesions. I've done some popliteals that were just nothing but rocks. It took forever to get a wire across it, but when I got through, I had stent-like results after I did that and did low balloon inflations. I typically do low balloon inflations on every atherectomy that I do. And if you want to get back to that, as far as atherectomy goes, I think you ought to atherectomize before using a drug-coated balloon. I think you need to get as much of the plaque out of there and get closer to the intima as you can. So, or the medium, and then, well, actually the intima would be better. This is some cases that were done with the orbital, and it works well. Again, if you got a heavily calcified vessel, I highly recommend, through personal experience, that you put a distal embolic protection device down. They don't advocate that, but they do have a Viper wire. There's two types of Viper wires with this particular device, and one of them actually has a large enough tip on the end that you can take the Abbott NAV6 and pass it over that wire, deploy it, and still retrieve it. And so I do advocate that. This is, we're going to have to move a little quicker. This is the Jetstream rotational atherectomy. It cuts and sucks at the same time, and it can be used above and below the knee. This was a study that they had that they did. It was not a randomized trial. It's just basically so many patients looking success rate. All these particular devices have good initial success rates. You shouldn't have much difficulty with it. And they had 38.2% restenosis and target. I'm sure that changed a little bit down the road. I tell you what I like this device for, the Jetstream. Let's go back one more here. This device, I think, works very good in fairly fresh thrombus. I think it macerates it and it draws it out. It's actually indicated for thrombosed vein grafts in the leg. So, and it works, I think it works very well there. I've had fair success with it in other areas, but that's where I think it really works best. We, in the pivot, this is the newest player on the market, it's the Phoenix atherectomy. Interesting, it uses an Archimedean principle to where as it goes in and you attach, it cuts and then it draws the plaque all the way out. It's basically made for below the knee. It is made for below the knee. They did a trial, excellent success rate, a lot of mates, and then of course below the knee you're not going to stent. The only problem with is when we did the trial, if your SFA was pop-tail SFA was 4 millimeters or less, you could enroll them in the trial. But if it was greater than 4 millimeters, you couldn't. Well, there's not that many people, especially down in South Alabama. Everybody's bigger than I am. And they just don't have it. So mostly I did was below the knee on this. This is a patient that we did. As you see, horrible disease below the knee here. Posterior tibial actually reconstitutes down at this level. We went in, we did the atherectomy. We then took if you look at this, there again, I'm a big balloon guy. I did this right here is a vascular tract balloon, long balloon inflation. At that time, they were one of the few that had 300-length balloon. And you can see the double wire in there. Left it up for about 5 minutes, and you see we got excellent results there. So, interesting. What's cool is you can see the dorsalis pedis filling right there. All right. No matter what you do, you're probably going to have to go back and retreat people. You need to let your patients know that. You need to make their expectations what yours are. And there is no panacea. There's nothing that's going to cure everything. Drug-coated balloons are going to help us. I agree with no metal behind if you can help it. Sometimes you can't help it and you got to do it. And sometimes always know that you can always go back. And just know sometimes if you hold your mouth right and you position yourself in the right position, you can be successful. Thank you.